All right, so it's 9 o'clock and we'll get started here. Welcome to everyone to our roundtable lecture on perinatal substance use disorder. Thanks to Linda Griffith, who is our CPSP coordinator, and unfortunately could not be with us today due to being sick, but I'm just thankful for her inviting us to this space to learn more about such a pertinent and important topic. My name is Dr. Robin Lynchide Jansen, and I'm a family physician in Fresno. And I do obstetrics and newborn care at Clovis Community Hospital, as well as I work part-time for the Fresno County Department of Public Health. I'm very passionate about this topic as I see it affects so many of my patients. And unfortunately, right now, substance use is all too prevalent, and our pregnant patients are not immune from this chronic disease. As we move through our lectures today, I hope you will gain more insight into how substance use disorder is a chronic medical condition and what treatments are available to treat and manage our pregnant patients so that they can have a healthy pregnancy and a healthy future for themselves and their baby. Okay, so we have an excellent slate of speakers today, and this is our program here. We'll try to stick to the schedule. And I just am appreciative of all the speakers here today for giving of their time to be here to talk to us. These are our objectives that we'll cover throughout the lecture. And then just a few housekeeping items before we get started. After the lecture, you'll receive a copy of the slides, the patient brochure that we developed through Fresno County Department of Public Health, as well as the recording of the session. There'll be a short questionnaire to fill out our evaluation after that will also be sent to you. And if applicable, once you fill that out, you'll receive CME credit or credits for nursing too, if that's applicable for you. A big thanks to Stacy Woods at Fresno Madera Medical Society for helping with getting CME and sending out the e-blast and registration forms and getting us all organized here. Please feel free to put questions in the chat as we go through each lecture during the roundtable, and Stacy will be monitoring the chat, and at the end there'll be a time where we'll address those questions. So without further ado, we'll get started. I'd like to introduce Dr. Tipu Khan, who is Chief of Addiction Medicine and faculty at Ventura County Medical Center at their Family Medicine Residency Program. He's been recognized by the California Healthcare Foundation as an expert in perinatal substance use disorder and is board certified in addiction medicine and completed a fellowship in obstetrics. He has been involved in numerous collaboratives to address substance use disorder in pregnancy, including the California Maternal Quality Care Collaborative Toolkit on perinatal substance use disorder, and is active in the California Academy of Addiction Medicine. So please welcome Dr. Tipu Khan.
Thanks, Robin. And I apologize to the group. I am actively trying to lose my voice, apparently. So I will hopefully make it through this presentation and then lose it afterwards. So let's go ahead and start off by sharing screen and minimize these windows. So first off, thank you all for being here. I think that's the biggest first step we all can take in really addressing and acknowledging the fact that we have a opiate use epidemic amongst our society, of course, but then even much more so amongst our pregnant patients. And those of us that care for patients who struggle with substance use disorders, we already are treating a very marginalized population. And then you add on pregnancy on top of that, and you can't be more stigmatized or more marginalized than being pregnant, addicted, and poor. So again, hats off to every one of you that's here today, that's going to be listening later on, that's going to go out and lead change in your community because these patients really need us. With that, we'll delve right into it. Disclosures, I do speak for AbbVie and Alkermes on Hep C and substance use disorder treatment and consult for Indivire. The entire realm of really managing substance use disorders in pregnancy, a lot of what we do is off-label. So I will be discussing off-label use of medications during this presentation. Of course, I recommend that you follow FDA applicable guidelines and consult with an appropriate specialist if you're going to go off-label. So our roadmap today is we're going to kind of go over some of the unique physiology of substance use disorder in pregnancy. And then we're going to focus more on opiate use disorder today in this presentation and really talk about some of the different modalities for starting medication-assisted treatment in the setting of high-dose fentanyl. And I'll talk more about that when we get to that section. And I want to close it off with providing some breastfeeding recommendation for the mother-baby dyads, which is important. So with that, let's start off by talking about the dyad. I really look and I really encourage that when we think about who we're caring for, we think about that dyad, that unit, right? That it's not just a mom, it's not just a baby, it's both. It's a mother-infant dyad. And in that mother-infant dyad, we need to think about multiple different areas of how we approach that. Breastfeeding, maternal behavior and fears they may have, maternal medical issues they may need treated, like MAT or postpartum pain afterwards. Bonding between mom and baby to initiate that hormone cascade, which we know is really important. And then lastly, infant management. So NAS treatment, medical. So these are all parts of the infant dyad. We're going to focus mostly on the management of the mother in pregnancy today, but just reminding you all that there are other steps we need to think about as we build protocols and algorithms and treatment modalities for these patients. I'm not going to spend time going through this slide. I just have it there for you to refer to because we are going to use a lot of acronyms, and those who may not be actively practicing obstetrics, these acronyms may have, worked their way to the back of our mind. So I just put them up here so we can kind of remember them if you need to get to them as I talk over these things. So with that, let's talk a little bit about nature versus nurture. You can't really talk about substance use disorders without thinking through the epigenetics of substance use disorders. So I love this infographic because it really kind of describes the pathology of substance use disorders throughout someone's life. It's not, a decision that someone makes once and changes their life. It's not one exposure that changes their life. It's multiple different things that change the way our genes are producing proteins, which then change the way that we interact with society. And that's the entire concept of epigenetics, is that certain genes can be activated in certain ways based off what the environment is putting into the system. So what we want, of course, is that on top is a healthy lifestyle, which activates healthy genes and leads to wonderful family life and active family units. But what we often see is that on the bottom, which is that unhealthy lifestyle choices, along with, of course, trauma and stress, etc., activate these genes that we don't want activated, which leads to a perpetual change in that cycle. But it also leads to moms then passing those genes down to their progeny. So I think this is really powerful, and I want to pause for a second on this because the take home for me here is that, one, substance use disorders are complicated. It's not a let God, let go only. It's a complex biopsychosocial disease with a lot of different variables, including trauma, exposures, etc., that lead to the outcomes that we see. But the other take home is that when we do intervene and we help and we get into these steps where we can change which genes are being activated, we're changing not just that patient's life, we're changing the life of her entire progeny, right? So the life that she gives to her children and their children and their children. So we really stand to change generations of progeny by how we intervene in substance use disorder and pregnancy. So it's really important we realize that and understand how powerful that intervention can be. One of the pivotal studies that we discuss a lot in perinatal substance use disorders, the Virginia twin study, where they followed twins a long period of life, and essentially they looked at different variables, etc. Great study, bread and butter. But one of the things that we take away from this is that in the early years, so that bottom line, the x-axis, we see up until about 9 to 14 years of age, what we're finding is it's really a mix between social and genetic factors that drive a lot of our substance use disorders, like caffeine, alcohol, nicotine, etc. But a lot of that really truly is genetic. But then when we get to that 13 above, where we start getting a lot of societal factors, peer groups, etc., you get that complex interplay. So the take home here is that there is a genetic predisposition to substance use disorders, but it is markedly affected by your environment as well. So we're going to follow Emily through this series here in a couple different ways. So let's start off with talking about Emily. This is, when I built this presentation, I built it around Emily, who was a patient of mine. This is exactly a patient I've been seeing over the last couple of years. And very likely, my guess, Emily is going to sound very, very familiar to each and every one of you as well. So Emily is a 25-year-old. She's actively using fentanyl. What can you offer her to reduce the risk of what we just discussed? So take a second and just kind of think about big picture, right? Epigenetics, pregnancy, passing on genes based off triggers, off of environment, drug use, etc. What can we do to help prevent those bad outcomes, prevent the bottom picture in this slide? So I just use this as a moment to pause and remind us all that we all should be empowered to really emphasize patient-driven birth control, right? So we really need to talk to patients about appropriate birth control, offering a long-acting reversible contraceptive when it's appropriate, but doing so in a way that's not birth control coercion, right? Really empowering the patient to feel comfortable to have that discussion about an appropriate birth control method. But this is one of the easiest things any of us can do. Even if we don't feel comfortable managing opioid use disorder, we want to refer that to someone else. We don't feel comfortable managing the alcohol, etc. One of the first steps we can do when this patient walks in our office is, hey, Emily, what are you doing for birth control then? Let's make sure we empower you so you get pregnant when you're ready. How can we help you in that regards while I get you connected to substance use disorder treatment? Okay, well, we didn't do that, and it didn't work. Emily comes back, finds out she was pregnant. You do a screening history, you find out she has a history of OUD and AUD just off of what she tells you. Is there validated screening tools that we should use to screen for active drug use and or substance use disorders? So we're going to take a second to kind of think through that. And I'm sorry again, because this is online, we can't have everyone unmute and kind of flood the realm, but just kind of think through it for a second. Is there anything that you use in your practice to screen? And is there any data? Should we even be screening? Is it supported? So screening does have a lot of good data behind it. Both ACOG and the USPSTF recommend screening as it has been shown to be effective. You want to screen at the first prenatal visit and then every trimester based off risk if they're a high risk patient. So if there's someone that's got ongoing substance use disorder, etc., that's someone that you're going to want to screen probably every trimester. But we recommend universal screening across the board, first prenatal visit for everybody. And a lot of us might be thinking this. I've heard this multiple times. Well, we don't have those patients in our practice. And you all, as leaders, may be out there talking to clinical providers who tell you, oh, we don't get those patients in our practice, so we don't need to screen for them. Those patients are there. We know they're there. The data says that. And that's why both ACOG and USPSTF recommend that we screen, because those patients just aren't being picked up. That's the first thing we can do, is pick these patients up appropriately. These are all validated screening tools, some alcohol-specific ones, and then also the general substance use disorder and domestic violence screening tools. I like the 4Piece Plus, got no vested interest in it, but I think it's a very quick screen that can be done relatively easily. It's validated, and it covers both substance use disorder and domestic violence. And then Medicaid pays for it. Every county is a little different, but in Ventura County, Medicaid pays for it. I think it's around $85 for the first screen and then $34-$35 for the subsequent screens. So not a ton of money, but these add up, right? If every patient, you do this on their first prenatal visit, that's on top of your standard billing. So thinking about and thinking through how to implement a screening pathway. Okay. So with that, let's talk a little bit more about the mother now. Let's focus in on the infant dyad. So in general, management of substance use disorder, the Just Quit method may actually work. There is data out there that the let God, let go, the Just Quit, say no to drugs may work actually in mild disease. However, most patients that we deal with don't have mild disease, right? Mild disease is defined as 2 out of your multiple criteria in your DSM-5 that we use to diagnose it. So if you've got a patient who just started drinking a few months ago, Just Quit may work, or they've got a very strong social support system, a lot of family behind them, etc. It may work. But in general, we know that doesn't work, which is why we recommend medical management. And we know the data also tells us very clearly that treatment works better when it started in pregnancy rather than waiting till after, because you will get patients who say that, who say, well, I don't really want to start MAT right now when I'm pregnant. I'm just going to kind of make it through it, and I'll start it afterwards when I deliver. And the data actually says that that doesn't work. And we have better treatment success when we institute treatment earlier in pregnancy. These moms are going to be scared, right? I mean, again, you can't be more stigmatized than being pregnant, addicted, and poor. So you really have to build your office to support these moms. Help them understand the process of guilt they're going to feel, the fear. Is CPS going to be involved? What does that mean? Are they going to take my child away? How do I get reunification with my other children? How do I parent? I had a mom ask me that one time. I don't even know how to be a mom. My mom was never a mom to me. She gave me heroin when I was 11 years old. I don't know how to be a parent. So much fear and guilt that these moms are struggling with that we need to acknowledge. We can't just see them for an OB visit and walk them out the door. We need to ask these open-ended questions in order to really get responses and connect them to resources. Reunification tends to really be a driving factor for treatment engagement. A lot of moms who may already have children that are within the system, not in their custody or custody of another family member, the ability to be able to get onto treatment during pregnancy, and the fact that a lot of the drug courts involved in the counties will then allow you to work on reunification after you deliver with your other children is a driving factor. And I've seen wonderful success stories with mothers who their reunification part with their other kids is really what supported them getting through that pregnancy. And I just, in general, always teach this to my fellows, my residents, my staff. When I talk about this, is it's just in the end, you got to meet moms where they are, right? Every day is a disaster for them. Them just trying to figure out how they could get to your appointment, right? Who's going to watch my other kids? How am I going to get a ride there? Who's going to watch my stuff so it doesn't get stolen? And then on the way there, I ran into a friend and he had something that I needed, so I used. I don't want to go to the doctor now. I'm embarrassed. Every day is a disaster. So be open and be accommodating. If that patient ends up coming in 20 minutes, 30 minutes late to their appointment, or calls and says, an hour later, I'm on the bus, I'm on my way in, be accommodating. Think about expanded clinic hours, thinking about having different clinic policies like walk-ins, et cetera, to be able to accommodate these women, because they really are, every day really is a disaster for them. And they're struggling to come in. And when they come in, we have to capture them. We don't want to lose them. So the last thing you want, and it always breaks my heart when this happens, is when they make it to your appointment and they're turned away by the front office because they're 20, 30, 15, whatever, X minutes late. And thinking about all that went into getting them there to your door, because we may not get them again after that moment. Okay, so with that, let's switch gears to opiates. I focus most of this conversation today on opiates because this is really the big epidemic we're seeing right now in our communities, right? So can you use naloxone in pregnancy? Yes, you can definitely use naloxone if there's a life-threatening overdose. So if someone has a typical opiate overdose and you need to reverse them, reverse them. But remember, though, that this can increase the risk of preterm labor or spontaneous abortion or miscarriage. And the way I like to teach this to patients when I give them naloxone and instruct them on how to use it in the field is I tell them that think about what happens in opiate withdrawal. You got a bunch of muscle cramps, right? You start, your legs hurt, your arms hurt, and your intestines are just muscles. So they start contracting and that causes diarrhea and vomiting. And so, oh yeah, that makes sense. I follow that up with, well, did you know that the uterus is just a giant muscle? So if all your other muscles are overactive when you're withdrawing, what do you think happens to the uterus? And oh yeah, that makes sense. And so they understand that they can start contracting. So even though we have a lot of reversals in the field all the time that we all see, we treat, we take care of, that don't come into the hospital, this is the one category of patient we have to continually emphasize needs to come to the hospital. Pregnant patient that's reversed needs to call 911 and come to labor and delivery to be evaluated for monitoring. That monitoring range depends on how far along they are in their pregnancy, of course, but we definitely want to make sure that they're monitored after being reversed. Withdrawal management, in general, is not recommended as it leads to higher rates of relapse and increased IUFD, which is fetal death and other fetal effects. And we'll talk about that in a second. When it comes to medication-assisted treatment, methadone was the gold standard, but buprenorphine really has gained acceptance as being non-inferior. So we treat those both equally, and we have to identify which patient would benefit from which one. So one thing I like to also teach is that methadone isn't a bad drug. You're going to have a lot of patients tell you, I don't want to be on methadone. I hated methadone. And they may have not had the best experience with it, but I always teach them that methadone is a really wonderful drug. It's saved millions of people's lives. And it's a medication I use all the time. I will definitely try to use buprenorphine as much as I can, but there's some patients that a partial agonist like buprenorphine is just not going to suffice for the physiology of disease that they have. And those patients really do need a full agonist like methadone. So again, I know we have a broad audience here, everyone from physicians to PAs and NPs and CPSP and community workers, et cetera. We all play a role in this. I've had so many patients who have come to me and said, my social worker said I can't be on methadone when I'm pregnant, or my CPSP worker told me I shouldn't be on methadone, or my probation officer said I can't be on methadone when I'm pregnant, or I'll be in trouble. So really, we all play a role in emphasizing that methadone is the gold standard for pregnancy. And it's as good as buprenorphine, and it's medication we should continue to encourage in the right patients. So what does MAT do in opiates, in opiate use disorder? Why do we even talk about MAT? Well, in general, what we know is medication-assisted treatment leads to more stable drug levels, which leads to less stress on the fetus. What we don't want is this. We don't want a high and a low, a high and a low. And that's what happens when we normally use, right? If we inject a gram of fentanyl, we get high, then it starts coming down, and then we inject again. That peak and trough causes stress on the fetus. Because the fetus also experiences that peak and trough. So they're experiencing a little bit of withdrawal, a little bit of euphoria. So what we want is stability to that level. And that stability is what's able to keep the fetus safe and the mom safe. So that's what we want, is stable drug levels. And that's what the MAT does for us. Lots of data out there. I'm not going to go over it in detail, but in summary, lots of data out there that shows that MAT decreases mortality from opioid use disorder, decreases drug overdose, decreases acquisition of HIV and hepatitis C, decreases relapse in comparison to abstinence-based treatment and detoxification programs, and leads to better maternal nutrition and prenatal care. So not only are you helping to reduce their mortality, you're also improving their morbidity because they're less likely to get an infectious disease, and they're more likely to come to you to get their maternal care, prenatal care, etc. And one of the things I didn't put on here also is STIs. It decreases overall STIs. We've also seen that it's decreased the acquisition of things like syphilis, et cetera, but also increased the rate of treatment for those because these patients are now coming to their prenatal visits to see you. So you're actually screening them and catching it and getting them treated rather than them going untreated all pregnancy with syphilis and giving birth to a baby who then has congenital syphilis. So that's a great thing to think about as well. Just gonna pause for a second. Sorry, like I said, I'm trying to lose my voice, so I'm hanging on to it for now. Okay, so let's talk a little bit more about methadone. Maternal doses don't correlate with NAS severity. And that's important because moms will tell you, I don't want to be on methadone because I don't want my baby to withdraw, or I don't want to be on MAT at all because I don't want my baby to withdraw. And what I tell women is that comparing methadone to buprenorphine, NAS severity can be different, but the dose of methadone you're on doesn't necessarily change how bad your NAS is going to be. And I've had this experience many times where women will say, I'm on 40 milligrams, I don't want to go up more than that, or I'm on 50, I don't want to go up more than that. Even though they're having withdrawal, they're having symptoms, they're flush, they're anxious, they're having cravings, but they just don't want to increase the dose because they're worried their child's going to withdraw. So I help emphasize that methadone is an interesting med, and we just don't understand the physiology of it completely. But I've had women on 50 milligrams of methadone who their babies had some NAS. I've had women on, I just delivered one last week that was on 130 of methadone, and the baby had mild NAS, but did not require any actual treatment other than eat, sleep, console. So it really varies. So just emphasize to the mom, the most important thing is that the methadone is at the dose that's going to work for you. That's going to help take care of your cravings, help ensure stability, and keep you happy with where you are and avoid use. And what you'll oftentimes see us do is we'll increase the dose in the third trimester, a lot of physiology changes in pregnancy, but basically more plasma volume, decreased protein binding. So methadone gets metabolized and cleared differently. The half-life changes. So usually around end of second, third trimester, it's typical for us to dose the methadone into twice daily dosing and increase the dose. So again, whatever your role is, as you support moms through this, if you note that the mom says, hey, my methadone's being split into twice a day dosing and they're going up on it, support them in that. The reason it's happening is because there's a physiological reason in the second and third trimester pregnancy, most women need a dose change in their methadone. So that's pretty typical. One of the questions that pops up is, well, when do I change the methadone dose? And we usually recommend, again, doing it a few weeks after postpartum, after they deliver, because those changes we just talked about, plasma volume, etc., that doesn't go away right when you deliver, right? It takes a while for your plasma volume to come down, all that stuff to normalize. So usually we do this as an outpatient in methadone clinic. So those of us working on labor delivery and postpartum, we just continue the methadone as is. We don't need to change it. And then in the outpatient setting, sometimes we'll use the trough level to help dosing if patients are having symptoms. Okay, so on to buprenorphine. Buprenorphine really is considered first line now. Like I said, equal to methadone. In general, the nice thing about buprenorphine is you don't have to change the dose during pregnancy. Buprenorphine is not plasma and protein bound. It's not plasma concentration dependent and not protein bound. So we don't need to worry about changing doses. So if someone comes to you and they're on 16 milligrams of buprenorphine, they're probably going to end up with just 16 milligrams of buprenorphine all through their pregnancy. You don't have to adjust the dose. Every once in a while, I will divide the dose for other effects of buprenorphine. Buprenorphine is an interesting med. One of the things it does is it has kappa receptor antagonism. The kappa receptor is part of the anxiety pathway. So sometimes splitting that dosing of the buprenorphine helps treat anxiety, actually. And a lot of moms will start having worsening anxiety when they're pregnant for lots of different reasons. But one of them is, again, what am I doing with this child? How do I keep this baby safe, etc. So oftentimes I will divide the dose for anxiety. But from an opiate use disorder standpoint, buprenorphine is pretty easy. You don't need to adjust it during pregnancy. But do remember, like I said earlier, if the buprenorphine is inadequate, they're still using on top of the buprenorphine, having cravings, they're maxed out, it's not working, really support the idea of moving up to methadone as the next step. Again, there's some patients who have such significant exposure to opiates. And again, that epigenetic change has happened over time that a partial agonist like buprenorphine just is not going to be enough for them. They really do need a full agonist like methadone. Okay, so let's go back to Emily, excuse me. Emily is back a year later with an unplanned but desired pregnancy at 26 weeks. You diagnose her with severe opiate use disorder. She says, hey, doc, I want to detox off fentanyl now so my baby doesn't kick when she's born. How do you answer? So how many of you have heard that? How many of you had patients that tell you, I just want to get off drugs now so my baby's okay? All of us, right? Every mom wants that for her child. Every mom wants her child to be born safe and healthy. But what we need to think about is, what does that mean to the fetus and the risk to the fetus? So the way I like to conceptualize this is I like to think about it as this concept of intrauterine abstinence syndrome, or what I call IAS. And essentially what it is again, as that fetus withdraws, because again, the fetal withdrawal coincides with maternal withdrawal. When the mom stops using drugs, it's no longer going past the placenta. The fetus is also withdrawing physiologically. In general, a lot of these withdrawal states causes what's called a catecholamine nexus, meaning your fight or flight hormones get ramped up. You get sweaty, your heart rate goes up, you really feel sick. And that causes you to be hyperactive. And to compensate for that, the body needs to suck in more oxygen, right? So for us, that's fine. We breathe faster, we increase our heart rate. That's how we increase our oxygen consumption. We have ways to compensate for that. However, remember the placenta has a fixed flow to it. The placenta can vary to some extent, but there's a max of how much blood flow the placenta can get over to the fetus. So the fetus can't compensate as well as you or I can. We can increase our heart rate from 60 at rest all the way up to 140 when we're really sick, right? And we can increase our respiratory rate from 10 at rest all the way up to 30 when we're really sick. So we've got a lot of compensatory mechanisms that we can activate. However, the fetus is restricted by the placenta. So what happens is that increases the risk of asphyxia to that child, which then causes a reciprocal constriction of the placental vessels, meaning the blood flow from the placenta going to the baby gets smaller and tighter. So that becomes harder for the child to actually compensate. So that leads to things like intrauterine growth restriction, so small babies, preterm labor, placental abruption, where the placenta actually comes off, and fetal demise, fetal death. And all of this can get worse, actually, when you use a vasoconstrictor on top of your other drugs like meth or cocaine. So anyhow, this is what I try to explain to moms in terms of why we don't recommend detox or withdrawal, because this is what you're going to be facing in your child. Now, do some women withdraw and do fine? Yes, definitely. I've had plenty of women who've told me, I don't care what you're telling me, I'm going to detox because I don't want to put this child through NAS. And they do okay. But there are also many bad outcomes I can tell you of women who have done exactly this and have come in with a fetal death or an IUFD or an abruption. So these things happen. So you really want to recommend that, yes, you may be able to get away with it, but the risk is so high, we don't recommend withdrawal management at this time. And that's the ACOG and ASAM committee opinion. So this is the ACOG ASAM official opinion that medically supervised withdrawal, aka detox, is not recommended in pregnancy for that reason. Okay, so you talked to Emily about that. She says, you're right. Okay, I don't want that to happen. I really wanted to do the best I can, so I'm not going to detox. And yes, I would like to start MAT in that situation. What should I use, methadone or buprenorphine? And the reason I really built this into the case is because this is something, again, in all of our avenues of how we treat patients, we all deal with this. Physicians deal with it, our CPSP, our social workers, our caseworkers, probation officers. This goes to everybody. So we all have to be uniform in how we answer this. And there's good data. Again, another pivotal study called the Mother Study, a large multi-center trial that was housed out of Johns Hopkins, but had 7 sites. I looked at buprenorphine versus methadone in opioid use disorder. They use pretty typical doses of methadone, 20 to 140 a day. Excuse me. They also use typical doses of buprenorphine, 2 to 32 milligrams a day. They followed 96 mother-child dyads. And the cool thing is they followed them up to 3 years of age. So they also followed their pediatric assessments, their well child checks at age 3 months, 6 months, at 12, 24, and 36 months as well. So they follow these kids out for some time. Wonderful study. If you ever get a chance to take a look at the Mother Study, I highly encourage it. It's another bread and butter study about treating women with substance use disorder. But here are the take homes. Children exposed to buprenorphine or methadone during pregnancy had a normal 3-year physical and mental development, meaning medication-assisted treatment in pregnancy does not affect development. That's a big take home, that as long as you get that steady state of medication, like we talked about, not the roller coaster, the steady state, it does not affect development in these kids. Number 2, children who required neonatal abstinence syndrome treatment did not differ in meeting developmental milestones, meaning if your kid does require treatment for NAS, the severity of the NAS does not affect development. So yes, you're on 40 milligrams of methadone and you're worried about going up to a higher dose, or you're on 100, you're worried about going up to a higher dose. The severity of NAS based off of 40 milligram exposure or 120 milligram exposure, it doesn't change development as long as it's managed. So don't worry about that part, just be treated. Number 3, buprenorphine efficacy is comparable to methadone. We've talked about that multiple times. It's just re-emphasized that bup and methadone are equally efficacious. And buprenorphine babies use less morphine. Basically, bup is easier on babies than methadone is. And that's what this graph shows us from the Mother Study. So in green is methadone, in purple is buprenorphine. Those babies that were exposed to buprenorphine were in the hospital shorter on average. They had a less duration of withdrawal treatment, and they had a less total dose of morphine that they required. So when I have an option, I will always choose buprenorphine over methadone if they both are going to work, because I know that there's a milder NAS and a shorter length of stay with kids that are exposed to buprenorphine. However, that's not a reason for me not to offer methadone, right? If methadone is the right medication, we're still going to do that. And that's why buprenorphine has gained in popularity, because it also leads to better NAS management for the children. So you talk to Emily about that. You give her all that information and she says, okay, that makes sense, but how do I get there? Coming off fentanyl is going to be hard. I use 2 to 3 grams a day, and I've heard of friends having horrible withdrawal when they try to start buprenorphine or they try to start methadone, they get sick. So how do we induce MAT in the setting of high dose fentanyl? So let me kind of frame this in the context of different induction mechanisms that we have that we've used in the past and we continue to use. On the left is the induction at the doctor's office. That's a typical induction that we used to do, and that we still do oftentimes. And you're there to check them, watch them, make sure they're doing okay. If they get sick, you can manage them while they're in your care. You can have a counselor check in and do some behavioral while they're there as well. But the downside to it is the patient may not be as comfortable as being at home. And then oftentimes they need to have someone take them home because they just started a MAT. We're not sure if they're safe to drive. But if they do it at home, the pros to that is they're going to be able to be in the comfort of their own home. They don't have to drive. But the downside is we just don't know what their withdrawal is going to be like. Again, with fentanyl being really tricky, it can make induction hard. What's tricky about fentanyl, is this. is fentanyl has multiple metabolites. Those metabolites are lipophilic, meaning it likes to hide in fat cells. So even though fentanyl itself is a rapid onset drug, we use it for acute pain and labor and delivery in the ER, et cetera. It's a quick on, quick off drug when used pharmaceutically. Over time and use it regularly, it builds up metabolites into the fat. So when you traditionally start someone on buprenorphine, they may actually have precipitated withdrawal because even though they didn't use fentanyl in 2 days, they still have fentanyl seeping out of their fat cells. So they still have some detectable levels of fentanyl in their blood or metabolites. And that can lead to precipitated withdrawal in the process. And that's what makes it really hard with fentanyl. With heroin, it was pretty straightforward. We would do home inductions all the time. Fentanyl is a little bit harder because of the fact that it sticks around longer. It's in a way, it's almost like methadone, which is a long-acting medication. It's a little harder. So home induction may not be appropriate for a lot of these patients. But when I do home inductions, this is my algorithm. I'm not going to go over in a lot of detail, but I have them do what's called a SALS, which is a symptomatic opiate withdrawal scale. And then based off that, they give themselves some buprenorphine and they check it again later in the day. Based off their score, they can take another strip. That's how I traditionally approach the home induction. Then on day one, the second day, they're going to take the total dose of day one in the morning. If they feel sick, they could do another dose in the afternoon. And then day 2 again, day 3, they take their total day 2 dose in the morning. And then if they feel sick later in the day, they take another strip or 2. Not going to spend a lot of time on the details of the actual induction because you can find that in the slide deck or review it elsewhere. But just reminding us that home inductions is one way we can get there. But let's talk about home induction versus treatment facility. What we want to avoid is confusion. That's the other part too, is with home inductions, it's hard sometimes telling patients to follow this algorithm. Not every patient is going to cognitively or socially be in a situation they can do this, in which case we may set them up for failure trying to ask them to do a home induction. So maybe that's someone that needs to be done in a clinical setting. So with our in-office induction, we talked about it a little bit ago, and then we could also do a hospital induction. But of course, remembering that a hospital induction can be intimidating. You're in a hospital with nurses and physicians, and not everybody may be up to date with their destigmatization training, and you may be getting judged by your nurses there for being there or your doctors for being there. So there's a lot of stigma and fear with the hospital induction process we have to acknowledge. Okay. So with that, let's talk again a little bit more about why fentanyl is tricky. And the concept here is fentanyl can trigger what's called precipitated withdrawal. On the top, what we see is that the orange is the drug, and then the blue is the buprenorphine. So this patient on the top left here is taking fentanyl. They feel good. You give them buprenorphine, it kicks all the fentanyl off, and it basically takes them from 100 miles an hour down to 40 miles an hour really, really fast, and that makes them sick. That's called precipitated withdrawal, where you knock off all of the fentanyl that was on your receptor and you replace it with buprenorphine. And because buprenorphine doesn't cause activity, it just binds to the receptor. They don't get the same effect, so they get sick. So you're taking the car from 100 miles an hour and slamming the brakes on and dropping it to 50 miles an hour. And that really sucks, right? Opioid withdrawal is a hard flu-like withdrawal. A lot of patients can't tolerate that, and they'll go out and use again to get rid of that feeling and then never want to go on buprenorphine again. So that's why we have to be careful how we approach it. But when we do kind of more tapered regimens, what we call micro-induction, we slowly introduce the buprenorphine. So this patient has some of their fentanyl on board on the bottom here, bottom left. We give just enough buprenorphine that it maybe takes 2 of the spots on the receptors, but leave some fentanyl there too. So they go from 100 miles an hour, maybe down to 70 miles an hour. And then on day 4, they go down to 50 miles an hour. So rather than slamming on the brakes and going from 100 miles an hour to 50 in 20 minutes, we're taking them from 100 miles an hour to 50 miles an hour over the course of 4 days. That's the concept of microinduction. So that's one of the novel strategies we're going to talk about here in how we do microinduction and how we get patients on buprenorphine. So the next set of slides are a lot of off-label use of medications. I'm not going to go into a lot of detail other than, again, because I know this is a varying crowd that's here from physicians to caseworkers, et cetera. My goal is to just introduce you to some of the methods we're using in pregnancy to stabilize patients that are relatively novel strategies that we may need to think about in the era of fentanyl. So this, again, is an overview of traditional microinduction of buprenorphine. You take these micro doses of buprenorphine, like a 1/4 milligram a day on day 1, 1/4 milligram twice a day on day 2, et cetera, and you build up until you get to day 5 to 7, a good dose of 12 to 16 milligrams buprenorphine. That's a traditional microinduction using the sublingual film or tablet. Some of the novel strategies that we're using now for beep induction also include using the buprenorphine patch. And what you could do on day 1 is continue your prior opiate and then apply a patch on day 1. Day 2, reduce that opiate dose while keeping the patch applied, so that patch is slowly starting to bind to that receptor. And day 3, you stop your opiate that we're using, like your fentanyl, your heroin, whatever, and you keep the patch on, but now you start sublingual buprenorphine. And you continue that titration up to day 5, where by day 5, they're on no drug anymore, no fentanyl or heroin. You take the patch off, and now they're only on sublingual buprenorphine. Lots of variations of this. Some variations use multiple patches, some extended in from 5 to 7 days. Some do it within 3 days, but a patch is something that you can consider in these patients as well as part of the way you get there. This is the patch algorithm that we use in our institution. We base it based off of their morphine equivalent. So we figure out how much their drug they're using. Most of our patients are going to be using fentanyl, so they're on over 90 morphine equivalents. So we'll use either a 20 milligram or 3 20 milligram patches. And then we follow this kind of algorithm in giving them up to 12 milligrams of buprenorphine by day 5. So that's what we've used at our institution. The other strategy we can use is IV buprenorphine. A lot of hospitals have it. If you don't at your hospital, I definitely recommend getting it. This has probably been my most favorite way actually to stabilize patients on microinduction because it's so well tolerated. And basically the concept here is on day 1, you're continuing your full agonist. Your full agonist is your drug. Of course, in a hospitalized setting, it's not going to be fentanyl or heroin they're using, but you would give them a full agonist, hydromorphone, whatever it is that it might be fentanyl you're giving them, whatever, full agonist, you continue it. And you build up by giving them small doses of IV buprenorphine on day 1, 0.15, and then 0.1, and then 0.3. So you give them IV buprenorphine over the course of the day, that's slowly binding to that receptor. And then what happens after day 1, then you go to day 2, where now you don't have any more IV buprenorphine, you just start sublingual buprenorphine at this point, and you titrate that up over day 2, day 3, day 4. At the same time, you're titrating down your full agonist. So day 2, you continue that full agonist, but day 3, I usually cut it in half, and day 4, I stop the full agonist completely. So in about 4 days, what I've done is I started IV buprenorphine, increased sublingual buprenorphine, and stopped their full agonist, their fentanyl, whatever it is that they're getting. The other concept that we can do is a rapid methadone induction. So traditionally, we're taught with methadone, you want to start 30 to 40 milligrams on day 1 and kind of titrate up day 2, 3, etc. But again, with fentanyl, what we found is a lot of these patients just can't tolerate low doses of methadone. 40, 50 milligrams just doesn't cut it for them because, again, the fentanyl is so potent. So what we find ourselves doing is this rapid methadone inductions where we start them on 60 milligrams on day 1. Day 2, we've got them on 80. Day 3 on 100, and day 4, 100 plus. And of course, if they're pregnant, we're going to split that dose throughout the day for them, latter part of the pregnancy. But by day 4, we've got them on a hefty dose of 100 milligrams. And this is kind of the base that we use to start with, but we tailor it. We have had patients that have gotten up to 120 milligrams by day 4. We had a patient we started recently on 80 milligrams on day 1 because they really needed it and they tolerated it. It's a dosing that, of course, we would do in a monitored setting like the hospital because it is high risk. We're giving them a big dose of methadone. And methadone has a long half-life. It sticks around for a while, so you have to be careful. But this patient was using 3 grams of fentanyl and was having a horrible time trying to get on medication. So we hit them hard with 80 milligrams of methadone on day 1. And they did good. They got up to 140 actually by day 4 and 120, sorry, by day 4 and did well. So thinking about high dose rapid methadone induction, again, in a monitored setting. So there's lots of ways we can get there when you think about medication-assisted treatment. We can do it from home. We could do it from the office in our clinic. We could do it in the hospital. These are all different ways we can get there. And in the end, the goal of all of these different modalities is to get our opiate use disorder patients on medication-assisted treatment because we want that healthy dyad, which is what we're shooting for, right? So that could be either using IV buprenorphine, sublingual buprenorphine, the patch, the injectable depot buprenorphine, methadone, all to link them into prenatal care so we get a better healthy dyad outcome. And we had a great case we recently did that was exciting. We had a high dose fentanyl patient that we used IV buprenorphine, brought IV buprenorphine in, started sublingual buprenorphine, stabilized them for 3 days on sublingual buprenorphine, and then gave them the depot buprenorphine injection on the way out as they went to a residential treatment center. So that was a wonderful case that we're writing up now, but lots of different ways to get there. But the goal is provide MAT, whichever one of these modalities you use, provide some MAT to get a healthy diet and get that outcome we're shooting for. So Emily has an unstable living condition, concerned about her ability to start BUP. She says she wants to start it in the hospital because she just doesn't know how she's going to do this based on where she's at because she's suffering from homelessness. She successfully starts an IV-based buprenorphine transition. Use full agonist hydromorphone to bridge her. Day 4, she's on 12 milligrams of sublingual buprenorphine. On day 4, you give her depot buprenorphine, and she's discharged to a residential treatment center. She has, an uneventful remainder of her pregnancy and delivers wonderfully. So this really is a wonderful outcome that we can do thinking outside of the box with fentanyl. So, but we do that. She's at residential, gets good care. Now she shows up to your floor on labor and delivery at 38 weeks. She's contracting every 5 minutes. You work her up and you decide, yes, she's in labor. How do we manage her on labor and delivery? This is an important point that, again, we all need to advocate for when patients come in. Again, we've talked about this before. You understand preterm labor can occur in up to 40% of women with OUD, a little bit less with other substances. There is no specific obstetric delivery timing that changes. And I've had this question where I've had delivering providers say, when should I bring her in for delivery because she's using a ton of drugs? Normal obstetric delivery. There's no reason to bring them in sooner for any other reason, unless they have a medical indication. You really want to talk early about intrapartum analgesia. So if you're the OB provider, but you're not doing the MAT, get an appropriate consult from someone who understands MAT, can talk this through and come up with a plan for this patient. But what you don't want is you don't want Emily just to show up on labor delivery contracting every 5 minutes and no one knows what to do for her pain and says, well, she's on methadone, so we can't do anything, or she's on buprenorphine, we can't do anything. We want to think through this ahead of time and have a plan set up. That way, when she shows up, we all know what we're doing and we can treat it appropriately. So think about neuraxial analgesia, epidural, spinal, etc. NSAIDs, a lot of us have IV Tylenol in our hospital. That's a great NSAID you can use for pain. Of course, IV pain medications, and then different modalities and dividing the dose of MAT. So you can also split the dose of buprenorphine or methadone just to get better pain control on labor delivery or postpartum. And also make sure while you manage these patients on labor delivery, we educate staff and break down that stigma. You want to avoid that, Dr. Khan's special, which, in our institution, we do this a lot. We had that for many years where we just had those patients were labeled as being the Dr. Khan patient. And we don't want to do that. We want to really normalize the disease of substance use disorder and treat these patients just like we would treat our preeclamptic, our gestational hypertensive, our gestational diabetic, right? Treat it just like we would treat any other medical complication of pregnancy. So in summary, again, the mother-infant dyad is really what we're looking at in treating and understanding that substance use disorder disrupts every part of this dyad, which is why we need to work together in a multidisciplinary fashion with all of our team members, our prescribing providers, our behavioral providers, our CPSP workers, our caseworkers, probation officers, drug court, reunification, CPS. We all need to really break down the silos and work together if we want to maximize the health of this mother-infant dyad. But to end, what we're going to do is focus real quick on the postpartum management and breastfeeding, and then we'll wrap it up. Again, treat the pain. You can divide the MET doses. Sometimes what I'll do is I'll take the buprenorphine if they're on 24 milligrams a day. I'll break it up to Q6 hours and give them 4 milligrams every 6 hours. That helps a little bit. Or if they're on methadone, give them an extra dose of 10 milligrams or 5 milligrams of methadone for pain. Use an NSAIDs, and then use a full agonist if you need it. And you want a potent full agonist if someone's on medication assisted treatment. So if they're on buprenorphine or methadone, giving them a little bit of morphine is not going to do anything. It's not going to bind to the receptor. It won't touch them. You need to use something pretty potent like fentanyl or hydromorphone, something that's going to actually be able to bind to the receptor enough to relieve their pain. Okay, so to wrap it up, this table I created is kind of a combination of data from LACTMed as well as the ABM clinical protocol for breastfeeding. And I like to review this to kind of go over what we recommend and don't recommend in terms of breastfeeding and pregnancy. So if patients are on methadone or buprenorphine, they should definitely breastfeed. I was blown away actually that I've heard this from lots of different people that they're told not to do it, but I was blown away for the first time. I had a patient 2 weeks ago who came to establish prenatal care with me, and it's going to one of the local methadone clinics, and she brought a paper with her, and on the paper it says, do not breastfeed when you're on methadone. And the paper looked like it was 50 years old. It looked like it was typed on a typewriter, copied 1,000 times. It was like sideways and crooked and folded. But I called the methadone center. I said, hey, this is like not standard of care. This is not up to date. You guys are giving this out to your pregnant moms, telling them not to breastfeed. We want them to breastfeed. It reduces neonatal abstinence syndrome, increases bonding, etc., immunity, all the stuff we talk about. And they were very receptive. They're like, oh my God, we didn't realize that. No one's ever pointed this out to us before. And so they went about working on changing it. So if you see that, just take a moment to provide that education to wherever you're hearing that from. We definitely want them to breastfeed on methadone or buprenorphine. Other opiates in general, yes, they can breastfeed. You want to have caution with codeine because of how babies metabolize it. It can increase their risk of respiratory sedation. So I generally do not use codeine in pregnant moms for pain or breastfeeding moms because I don't want that codeine going into the breast milk. Cannabis, we're not sure. That's a big one. Everyone asks about it, right? Everybody's using it now, and everyone asks about it. And what I tell moms is I just don't know. There's data coming out from Colorado where we've had it legal the longest and a lot of good studies that's starting to show there is cognitive delay in children that are exposed to cannabis through breast milk. But we just don't have enough data to say yes or no. So I don't recommend it personally. However, you may have to weigh the risk and benefits. If this is a high-risk child who needs that bonding, who needs the immunity, etc., you may want to do it. However, I generally don't recommend it, but I also acknowledge I don't have good data yet telling me which way to go. Alcohol, they can breastfeed. You want to wait at least 2 hours after the last drink, no more than a couple of drinks a day. And that's pretty easy to understand because alcohol has a very clear metabolism. You actually know the metabolism rate of alcohol. Tobacco is okay to breastfeed. Stimulants, we do not want people breastfeeding on stimulants because stimulants do enter the breast milk and this leads to jittery, stimulant activated kids. So we don't want them to breastfeed. Benzodiazepines, you can breastfeed, but we have to observe closely for sedation. So just good education there. Naltrexone or naloxone can definitely breastfeed. HIV is interesting. Our official recommendation for breastfeeding and HIV is that you should not breastfeed when you have HIV. However, the WHO says very clearly you have to weigh the risk and benefits. If you're in sub-Saharan Africa where you don't have access to vaccinations or clean water or nutrition, this child is more likely to die of a waterborne illness or malnutrition than they are from a long-term HIV complication if they get HIV from the mother. So they recommend breastfeeding in those situations. And there's a lot of good data out there also mounting that if someone has HIV and they're controlled, so they have undetectable viral loads, they don't have anything they can transmit. So I have an informed decision with patients, informed conversation with patients where I tell them my guidelines and recommendations currently tell me at this point in time, even though you've got undetectable viral loads, I can't tell you can breastfeed. However, there is mounting data that women with undetectable viral loads aren't transmitting any virus in their breast milk because they're undetectable, that it probably is okay to breastfeed. So I can't tell you what to do. I can tell you that medically, I can't recommend it yet. However, you would have to make the decision weighing the risk and benefits of what you want to do. And I've had a lot of women then come back and say, I've decided to breastfeed because I'm undetectable, et cetera. But again, you have to let the patient make that decision, but you need to inform them that we don't have data right now to support that. I personally think this is going to change in the next few years, but we don't have that yet. And lastly, Hep C, this is a big one, 30%, at least in our community. And in nationally, it's about anywhere from 10 to 12, but 10 to 15. But in our community, it's about 30% of women who inject drugs also have hepatitis C. You probably have a ton of hepatitis C positive patients in your practice. Again, we do this a lot in our institution, and I still run into this where I walk in on a postpartum patient to go round on the couplet, and there's a bottle at bedside. I'm like, how did that formula get there? We're a breastfeeding friendly hospital. I didn't order formula. My resident didn't order it. How did that get there? The nurses, oh, well, the patient has Hep C, so they can't breastfeed. And it's because we've equated Hep C with HIV for many, many years. But what we do know with Hep C is it does not get into the breast milk. If there's a cracked bloody nipple, it's blood-borne. So yes, you should not breastfeed if you've got a cracked or bloody nipple. But if you don't have a cracked or bloody nipple, you should breastfeed. We encourage it. There's no maternal transmission through breast milk. So we all can provide that education to our teams that hepatitis C, you definitely should breastfeed. We recommend it. So in summary, you want to treat substance use disorder in pregnancy with medication-assisted treatment when appropriate, either bup or methadone. You want to stay ahead of the pain during labor and postpartum. Come up with a plan. Use a multidisciplinary action plan. Use a consultant. Use your anesthesia. Use your nurse. Use your addiction specialist. Use your OB. Whoever you're using, but come up with a plan ahead of time so patients don't get surprised when they show up and the staff isn't surprised and doesn't know what to do with them. Don't stop MAT during the postpartum period. We know that doesn't work. It leads to worse outcomes. And lastly, create an open, inviting environment for these patients because they're so high risk. Everyone's shunned them. Everyone's stigmatized them. We're really the last chance for these patients to have a healthy mother-infant dyad and lead to the outcomes that we're all aiming for. My contact information, and with that, I will go ahead and end. Thank you.
Thank you, Dr. Tipu Khan. And I'm going to pull up. And I just want to remind people that if you have questions, please put them in the chat. We'll go through those at the end. And our next speaker is Dr. Shoaib Khan, who is Assistant Clinical Professor at UCSF Fresno Family Medicine Residency and runs a harm reduction clinic at United Health Centers in Parlier and Mendota. He does addiction medicine care and obstetrical care at CRMC, or Community Regional Medical Center here in Fresno. And it's an honor to have him speak to us today, and a privilege that he is here in Fresno and doing great work to address perinatal substance use disorder locally. So welcome, Dr. Shoaib Khan.
Thank you, Dr. Linscheid. I'm going to first apologize. I am on call and you might hear a bit of train going by or overhead pages. So that's because I'm in the hospital. I wanted to thank the Fresno Madera Society and Stacy and Dr. Linscheid for inviting me to talk today. And I'm really honored to speak to our CPSP workers and social workers and substance use navigators and public health workers and obviously physicians and nurses for joining us today. And as Dr. Tipu Khan said, really critical that we work together to address these issues, especially around pregnancy. I'm going to pull up my presentation and get on with it. Give me 1 sec. All right. And so, as Dr. Linscheid mentioned, I'm a core faculty with the residency department here at UCSF Fresno Family and Community Medicine. And I also teach addiction care along with obstetrics in the department. And this is my experience working in the 2 clinics here in the Fresno County area, but also I've been engaged in underserved and rural care in other parts of the country, including on the Navajo Reservation and in Oklahoma. And the idea today that I wanted to bring in is harm reduction for pregnant women, especially emphasizing on the social aspects that we see often in the CPSP workers, social workers, and the public health workers play such a critical role in providing this care in the rural areas. And emphasizing on that piece today. I do not have any disclosures. The objectives today is to discuss the impact of substance use in our rural populations, highlight some of the challenges that we have in treating pregnant women suffering from substance use disorder, and with a couple of cases. And then we created this harm reduction curriculum for our residents in the clinic in order to address some of the gaps of training that we have for our providers generally. And I thought we should share, I wanted to share that with you all as well, just in terms of what we are trying to address, how we're trying to address this gap of training. So just a quick personal narrative I wanted to share. One thing I observed during training at different stages of my career was that patients that were suffering from chronic pain or were on narcotics for various reasons or substances were considered by many of our folks as difficult to treat, or they provoked a negative emotional response and often were left either untreated or was a source of gossip and conversation, but not real really in line with equitable care and providing adequate resources for helping these folks. So that really, placed for me an important emphasis and interest in treating these patients. Um, the responsibility of the epidemic as providers and prescribers of these drugs really impacted me in terms of how we created this beast that we are now dealing with, actively engaging all our folks to kind of address this, and how could this have gotten this far, and how could we have prevented this. So just that really helped me move my career in this direction. And then my interest is serving the underserved and the communities that live in it. And most of these patients who are suffering from substance use disorders are found in these areas. And so it kind of was important for me to address addiction care. And then, at least for a few of these substances, we have good solutions, at least for the short term, maybe for the long, that we can learn about and save lives on an immediate basis. These are some personal narratives that I used to engage in during training, and then eventually, once I chose a career path, to just follow this path, as it was thing addressing many of the reasons for me to come, especially to Fresno area. And so I wanted to bring up some of the highlights on the news. You would have seen this commonly now being reported on national news. This was a story on NPR on how the White House was planning to address the drug overdose deaths. And I am glad and grateful that this is now becoming a topic of conversation on a national level. And it's been on the works, but now legitimate action is being taken on providing resources for these folks. And so, you can see from this, in the first detailed plan, harm reduction was the emphasis. And this is a very interesting story on them providing fentanyl test strips for drug users to just make sure that the drug that they're buying is not laced with fentanyl that can be lethal. And so many people have been lost because of fentanyl in the past year. This was another recent story from Fresno area. You would have seen some of the police activity and law enforcement activity around the areas that you were driving through or from. The M30 King of Fresno, and uh, the drug bust that they did, and they're actively engaged. I was part of this conversation with the district attorney's office about how to address this as well, and it was very encouraging to see that legitimate action is now being taken for the source of these drugs that are just trickling into our communities across the county and the state. This is a real quick table I wanted to show everybody to emphasize the impact of substance use disorder on the rural populations. And these could be considered as rural, Mendota, Parlier, small metros and non-metro areas, and the surrounding areas. And as you can see, compared to the larger cities, generally the drug use, alcohol use, smoking, um, um, methamphetamine use, and misuse of opioids, all of them are higher in these small and non-metro areas compared to larger areas where there's more emphasis, more resources, more physicians and CPSB workers, more resources for them to get treatment, and more emphasis from even law enforcement in controlling these issues. And compare this with the smaller areas where we have less of all of that, and we have higher rate of use as well. So there's a great need in the rural areas. And this came across just last month when we passed 100,000, a very sad milestone, uh, um, while we were tackling the pandemic, that the US now has passed the 100,000 mark for overdose deaths just for the year 2021. And so, as we know, during the pandemic, when all of our attention was focused on controlling the virus and treating the viral deaths related to COVID, overdose deaths have constantly increased, continue to worsen the epidemic of the opioid overdose deaths. And so we have passed that grave milestone. And so part of this news was just the emphasis on the rural areas where it has been particularly devastating during the pandemic. And it was because of the lack of access to care, as well as just lack of attention on controlling this pandemic during the epidemic during the pandemic issue time. And just in California, more than 10,000 people have died from overdose in 2021. This includes methamphetamines, which has also gone up, and opioid related deaths are majority related to fentanyl, but also to opioid misuse of prescription opioids. So just a few news related items that you may have seen or may not have seen. Wanted to emphasize on how this is a big issue in especially rural areas. Interestingly, this was a study from the Pew Institute, Research Institute, that asked folks that live in these communities that are suffering heavy losses from substance use disorder and overdose deaths, whether this was a concern or not. And what they found was that the interest and just the care about these issues is declining, despite of the increase in the overdose deaths in the same communities. And they attributed this to several factors, but their study wasn't focusing on the whys of this problem, but just generally impact of the pandemic in terms of job losses and loss of homes, and the attention given to controlling the virus, and the social, political, health related issues around that has kind of taken away the attention from this epidemic that we were suffering from before this pandemic arrived. And it's very interesting that folks don't think it's a big concern while the deaths continue to rise in these areas. And so I'm going to bring in this case of a young woman that I saw in one of our clinics, and interestingly came to us with a request of removing her Nexplanon that she had kept and gotten placed just 6 months ago. And this was after she gave birth to her only child. And when asked for the reason for her early request, she reported that she wanted to quit methamphetamines that she uses heavily. And while she is pregnant is the only time she can successfully quit. And she reported this motivation to quit when she got pregnant. And she thought if she could get pregnant again, she can perhaps consider, the motivation will be back in terms of quitting the methamphetamine. And so it's kind of, her description of her situation kind of shook me to the core, because what it showed was that she felt that this was the only way out. So the desperation in her voice and her attitude and her request was completely apparent. And plus, it saddened me because not only was her request a sign of desperation, was because also she had been suffering while she was pregnant previously and afterwards, and using meth in the meanwhile. She had lost custody of her child that she had born just 6 months ago. She was homeless without any source of income, and her sexual behavior was high risk. She was primarily getting these drugs in um, in return of a host who was allowing her to stay in the house and then providing sex in return for the drugs. And so she had reported over 70 to between 70 to 100 partners just based on this. And um, when she was describing herself, her problem, it was completely apparent to me that she was suffering from mental health issues that were not addressed and uh, not fully treated. And this could have been one of the causes that she perhaps was gotten into the substance use disorder, and um, no treatment was so far offered to her um, for treating any of these problems. Some of the challenges that were uh, were apparent to us in terms of getting her treatment. The nearest inpatient facility that we could get her to, if she had agreed to go there, was 40 minutes away, and there was no transport that goes to that extent. Even the clinic that provides some transport for local access to local areas was unable to provide transport for this long of a journey. There are a few prenatal care providers in this area, which our department is trying to address, but even fewer, even amongst our faculty who are um, trained to treat substance use disorder during the perinatal period. And this reluctance or hesitance is just common in generally obstetric providers, what we have seen. And in terms of behavioral health personnel, there was some counseling available at the clinic through our great CPSP workers, but no formal behavioral health counselors that were available. The closest one was 20 minutes away. And we unfortunately had to the clinic had furloughed the social workers during the height of the COVID-19 pandemic. So just all these were some of the barriers to care for this woman who was trying to get off meth for herself. Now, I want to share this tough drug to treat this drug abuse, the drug of abuse, the stimulant methamphetamine. It's one of the biggest problems that we have, especially across the country, but especially in the Fresno area. It's a powerful, highly addictive stimulant that affects the CNS. Crystal meth is a form of the drug that looks like small glass fragments, shiny bluish white rocks, and chemically similar to amphetamine. And it can be taken by smoking, swallowing as a pill, snorting, or injecting the powder that is dissolved in water or alcohol. We need three things. And so I'm just going to play this video real quick from a colleague of ours, Dr. Waller. And this is from the Health Management and Associated Addiction Department. It kind of describes the little bit of methamphetamine pathophysiology. We need three things to survive. You need food, you need water, you need dopamine. Now, some of the people who get a little antsy say we also need oxygen. Yes, well, we also need skin, but I'm not going to really talk about that today. We're going to talk about the three things we absolutely need to survive as a human in today's world, and that is food, water, and dopamine. We need dopamine because it's the chemical responsible for motivation. It's this thing that's responsible for us going and making a friend, having a mother have a bond with a baby. It's the thing that motivates us when we do good to do better. When somebody pats you on the back and says, good job, and you go to do something more significant, that's because your dopamine has gotten pinged and it's just something pushing you, this invisible chemical that's pushing you along the path. On a normal day, we even know how much dopamine we're supposed to have. So on Monday morning, when I wake up and I have to get up and I go to work, I live in the range of about 50 nanograms per deciliter of dopamine. That sits in the central part of my brain, and that's required for me to get out of bed and go get that first cup of coffee. Now, what about the worst day, the really bad day? The day you
call your office and you fake vomit in the phone and you decide not to go in. You're like, I just can't make it. That's about 40 nanograms per deciliter. So not much lower, but low enough to where you just want to sit around in your pajamas all day and do nothing. What about the best day ever? You know, the day where all at once you win the lottery, you have 2% body fat, and you're living on the beach. All of those things happen at the exact same time. We even know that one. That's 100 nanograms per deciliter. Our brain is meant to go all the way to there. It's not really meant to go above. And we can look at things like your favorite food, which is like 94 nanograms per deciliter. And sex, 92 nanograms per deciliter. Bummer, right? Couldn't have predicted that. Maybe they need to redo that research. But at the same time, we know that we're supposed to live within this relative normal state between 40 on a horrible day and 100 on our best day. So what happens when we add a chemical into the brain like methamphetamine? This chemical is really important because it pushes us way past that 100 nanograms per deciliter. In fact, it actually pushes up to 1,100 nanograms per deciliter, more than 10 times the amount of dopamine that our brain should be making. And then if we look at things like marijuana or alcohol or heroin, these are things that push it up into the high hundreds. This is not what we're supposed to be doing. As we look at this, we have the normal that we're supposed to be. We have this large jump for something like methamphetamine. And then we have these other drugs that drive that dopamine up. And when that happens, it starts to take over that part of the brain. And no longer does going to your child's birthday make you happy. It's not happening. The things that normally make us feel happy start to pale in comparison. This is because the brain is built to survive. In fact, we know that this is a survival issue for the brain, mainly because dopamine is what drives us to procreate, to get food, to get water, like we talked about. And we know so much about addiction and all of these things that are going on in that part of the brain that we actually know the parts of the brain responsible for this motivation and this dopamine release. It's places like the anterior cingulate gyrus, the lateral bed nuclei of the amygdala, the nucleus accumbens, the ventral tegmental area, the periaqueductal gray. We know this. And by the end of all of these videos on this site, you're going to know exactly what each of those parts do. But for now, you should understand that this area of the brain called the limbic system, which includes, but it's not limited to, the ventral tegmental area and the nucleus accumbens, are responsible for reward. And the fact that we can look on an MRI and see these parts of the brain working, and we can see them working in a patient who is not on any drugs, and those that have been on illicit substances for a long time, and see major differences in how these structures work, is really important because it allows us to start to understand things like behavior. We can see that all of the focus is on the dopamine part of the brain. Remember that nucleus accumbens and ventral tegmental area that we talked about? In that part of the brain, when you've been taking things like methamphetamine for a long time, every time that you take the methamphetamine, it goes from 1,100, then the next time maybe it's 900, then 600, then 500, then 200, then 100. Then you're required to take that drug even to get you up to that normal level of 50 nanograms per deciliter. Let's say we found this person, we get them into treatment and we remove that drug. Now we have people whose dopamine goes all the way down to as low as 10 nanograms per deciliter. And on their best day ever, it's only 20 nanograms per deciliter. These are numbers that matter, and we're going to keep hammering on these because when you have 10 nanograms per deciliter, you can't get out of bed. You can't get up to put your clothes on and go to a job interview or to even take care of yourself or your family. When we lack dopamine, the body craves it. And when you crave dopamine, you get into survival mode. And that leads to primal action. And that primal action is a lot of times the behavior that we see. How can they take grandma's jewelry? How can they steal a credit card? How can they pawn something that they own? Their brain is telling them that they are not going to survive if they don't get dopamine. And the thing that gives them the dopamine that they need, as far as they know, is that drug of choice.
So this is just a reminder of what happens to these patients when you're asking them to do something and they agree to do it, and they just cannot go through with the plan. and why they fail often, and why is it so hard and difficult for folks who are taking methamphetamine to quit it, even despite of seeing the bad effects and agreeing that it needs to be stopped. And so in small amounts, methamphetamines can result in effects similar to other stimulants, including increased wakefulness and physical activity, decreased appetite, fast breathing, rapid and irregular heartbeat, increased blood pressure and body temperature. On the long term, it leads to extreme weight loss, severe dental problems that we've often seen, intense itching leading to skin sores, anxiety, changes in brain structure and function, like we just saw, confusion, memory loss, sleep problems, violent behavior, paranoia, and hallucinations. When it comes to pregnancy, as was described in the previous presentation, it really does impact the pregnancy in a very negative way. It risks developing hypertensive complications during pregnancy. There can be premature rupture of membrane, placenta previa, abruption, premature delivery. It can precipitate labor, and it can lead to infections of the amniotic cavity and intrauterine death. It can lead to shorter gestational age, lower birth weights for babies, decreased head circumference and length, increases the rates of NICU admissions for these babies, and increases the risks of infantile death. But we do know that if these are stopped at an appropriate time during pregnancy, it still can lead to improved outcomes for these babies. So it's really, really important to not only investigate whether a person is taking it, but to help and encourage and support them to quit methamphetamines if they can. Just wanted to show you that this has been acknowledged, and this was a committee opinion on methamphetamine use in reproductive age. This was reaffirmed by the ACOG in 2017, where they say methamphetamine use in pregnancy endangers the health of women and increases the risk of low birth weight in small gestational age babies, and such may increase the risk of neurodevelopmental problems in children. So very important document, very useful. And this for our patient, we tried to get her into inpatient rehab. She declined, which was not unusual and not an unexpected behavior. But she, since she was not pregnant at that time, we were able to start mirtazapine and NAC that was at that time used as a possible supplement that helps with meth addiction and craving. We were able to provide her a local transport to counseling services that was now nearer, not in the same clinic, but 20 minutes away. And she started working with the behavioral counselor. We connected her to a psychiatrist, to a telehealth, who diagnosed her with schizoaffective bipolar type disorder. And she was started on appropriate medicine. And then we constantly, as a team, work together with our incredible CPSV workers and provided her with a lot of education resources, encouragement. She was often seeing 2 different types of providers every week. And it was really intense in terms of treatment. The good news for her was she quit using it and had not used for 8 months. When the last time I saw her, she came to her majority of her appointments. She was not missing any. She had no partners in the past 6 months that she was with us, and had kept her Nexplanon on her own, decided to keep it. Her family members, seeing her incredible turnaround, started supporting her treatment and encouraged her to stay in treatment. We were able to get her to find Section 8 housing, and she was able to get partial custody of her child. That was her initial motivation, and reported that her cravings had gotten better, and she did still continue to have bad days, but not too many. And this was a good news for us as well. For methamphetamine addiction, this is something that is really not, we don't have a good solution for it, unfortunately. For patients who are pregnant, we probably don't have anything to offer that is known to be safe, though we still try different things. And this was published last year, where they found bupropion and extended injectable drug naltrexone as an injectable drug to be helpful in cutting meth cravings by 12% compared to placebo. There have been increased interest in finding a solution for meth cravings, and this was what they called, in their own words, a breakthrough treatment, but it only impacts 12%, fairly small numbers, but still better than nothing when it comes to cutting cravings for meth. Another one of these trials on mirtazapine that we had used, it was seen before, and we knew about it, that was successful in helping men living with HIV to improve their sexual behaviors. This one, when used in 30 milligrams dosage, was able to produce a negative UDS at 6 months to 9 months, when checked at 6 months and 9 months after starting treatment. So another useful one. The NAC supplementation from this particular clinical trial done in Australia looked at 1,200 and 2,400 milligrams of NAC given orally. Did not really produce the impact that they were expecting to see, and this was a negative trial, so it's not as useful as we thought it would be. Fresno I moved here a couple of years ago, and I was little aware of the significance. This was a documentary by this British documentary maker, Louis Theroux, and he filmed this in 2009. He talks about Fresno as a city which is addicted to crystal meth. So just a little clip for that.
The next day, and I was heading back to Westcare for a final catch-up with Lynn.
Guide me in my recovery and show me how to live clean. Keep coming back, it works if you work it, so work because you're worth it.
How's it been going here at Westcare?
It's been kind of rocky. We had a death.
Did you?
Not in the program, but a child of one of our mothers who was struggling with respiratory problems and birth defects passed away at 3 months. And that was last week. We had the funeral yesterday.
That's very sad.
It was very sad. I get goosebumps.
When you get upset about that, what are you thinking about?
What a tragedy that it didn't have to happen. That there's education, there's services, there's prevention. That, our hope is that the CB plant here avoids it in the future. Maybe that baby had to die so some other mother who's using right now won't. It's tough.
Anyone here got a problem with meth?
Meth is a devil's drug. That's all I said. It's evil. It's bad. I mean, I'm 23 years old. I've already been in prison twice behind it. It's horrible. Takes your freedom. Takes your self-respect. Takes your self-respect. It takes anything positive you ever had.
What do you think it is that makes people recover?
A lot of it has to do with a single incident in time, like having a litter mate lose their baby. Others might be that finally they saw themselves in the mirror as they walked by a storefront and saw, oh my God, who is that person? Some folks come in here to avoid other things like prison and losing their children. And along the way, they discover they're not such bad people. And they're pretty good company. So they decide to like themselves. And once you start liking yourself, you start feeling entitled to all the good things life has to give you. And so you'll do things like take good care of yourself and say, no, I'm not going to hang out with you. Or that methamphetamine is ruining my life, but stop.
Would you say it's about severely damaged people from traumatic backgrounds, and that they'll find something to medicate themselves with no matter what?
Yes, I think you're right.
So just a little bit of what has been shown about Fresno. I wanted to bring in another case real quick because we're running a little short on time. This one is about a 24-year-old female, G2P1. She came to me at around 14 weeks gestation from another clinic that was uh, within our United Health systems. And she was seeing an obstetrician for the past woman who did not ask about any substance use from her. And she did not report it either, saying that she was never asked. And she felt that she would be judged if she did share that information voluntarily with them. She wanted to change doctors because she really wanted to quit this tramadol that she was getting from a flower shop, primarily to treat her anxiety and pain that she described having, and could not stop taking it once she felt better with it. And then she realized that that wasn't the best of ideas, and somebody somewhere had shared with her the issues around that. And instead of going back to her obstetrician, she decided to change her obstetrician. And so the reason I bring this up is, like it had been mentioned, it has been the committee opinion from ACOG is been to screen all people universally for substance use disorder, and it should be a part of comprehensive OB care, starting with the first trimester. And very often, a lot of our folks in our community who are providing obstetrical care just either are hesitant or reluctant or unable to do this. And it needs to be done because this is something that like any other chronic illness can be helped and treated and improved in terms of leading to better outcomes for our patients. So we need to understand substance use disorder, the chronic illness that can be treated even during pregnancy. And during pregnancy should be preferentially treated because it impacts not one but two patients at the same time. And as primary care providers or obstetricians, we need to learn the principles of harm reduction, including the role of MAT that we can use. And what we did as a part of this was to understand this gap of training. We really tried to understand why it was such a problem in terms of asking these patients about substance use disorder. Was it just neglect or something else? And it turns out a lot of providers just feel unease and uncomfortable in treating substance use disorder because it was just not a part of their training. Family physicians now are incorporating programs or incorporating this training curriculums into their regular routine didactics. But for example, in our own program, we were lacking that practical experience that would allow these young residents, when they become attendings, to utilize these principles, just because of the lack of appropriate practical knowledge. And there are several other reasons, I'm sure, and we are actually looking into this particular area through different research projects in our own department, through our own department. So we will have more information to share very soon. But we created this harm reduction curriculum that I'm going to go through in the last couple of minutes to address this gap of care. And so this is essentially how we see MAT, is that it's a life jacket for folks who are drowning with substance use disorder, and providing them with medication assisted treatment is essentially like providing a life jacket for these people. And so a little bit of background, we have had over 5,000 deaths just in 1 year. Opioid overdose related deaths continue to increase. Primary care physicians remain hesitant in providing this despite of didactical training. And there are known benefits to MAT for opioid use disorder, at least as a harm reduction strategy. And then there have been federal mandates that have improved prescriber access to providing MAT and from their own clinics. However, it is not as commonly utilized right now. So the objective of this curriculum that we built for our residents was to improve their practical knowledge and attitudes towards providing harm reduction principles and increase the number of physicians that can provide MAT for opioid disorder in a confident way. This is being done through the United Health Centers at Parlier, and where our residency clinic is located, and one of my harm reduction clinics is located. We allow the second and third years to go through this clinic during their continuity clinic months. And we are actually also in the process of evaluating how they feel it's going to impact their long-term careers. We came across several reasons to build this curriculum, but the two main ways that we assessed the need for this was we interviewed a bunch of graduates from our program, despite of didactical training, on how they felt about their own skill set for providing these harm reduction treatments for their patients. And we also reviewed in the first year of the establishment of our clinic all the referrals that we had gotten on what was the need of the time and for the areas that we were serving. And so based on that, we came across 5 big areas that we addressed in our curriculum and provide practical experience for those to our residents. MAT with buprenorphine for opioid use disorder, how to induce them, how to maintain it, how to taper off people that are taking prescription opioids, how to taper off people who are taking prescription benzos, addiction care as chronic care, how to think about it, how to provide options and care in that realm, and conflict management and negotiation with patients was such a big deal that a lot of our physicians felt uneasy about doing care through their own clinics because of the lack of these skills that were not practically provided to them during their training. We are deploying different ways. They come and observe me in the clinic. We call that activated demonstration. We review cases, we review literature. There's OSCE, where we have mock patients where they standardized patients that they work with to treat them in a OSCE situation. We have their self-reflection tool, which is also an evaluation mechanism on how they feel before and after going through the clinic for training. And we will be doing that pre and post rotational assessment. And we also plan to see how they feel at the end of their residency and at the end of the first year of an independent practice, whether this curriculum made a difference in their lives. And we hope to see that they are able to provide some of this work through their own clinic. And I think, in order to provide or make any big advances in addressing the epidemic, we all have to use these principles. And we're hoping through this curriculum, our residents will be adding to the pool of providers that can provide these care through their own clinics. We were acknowledged and we reported some of this to CAFP and in local journals. So for our patient that came to me, we induced her on Suboxone. That was her drug of preference, the drug of choice that she wanted to use, low dose, and she took that throughout her pregnancy. She delivered normally a 7.5-pound baby who did not need a NICU stay. She did have an extra day. She stayed 3 days in the hospital, but did not develop neonatal absence syndrome. And she continued to breastfeed without any problems for the baby. And she continues to take Suboxone and feels secure for cravings while she's taking it. She's around the 4-5 month mark right now. And what we've seen is a lot of times these women are started on treatment, and the CPSP workers and all of us are doing the best we can up to the postpartum visits. But then we kind of trickle down the intensity of the education and support, and it often leads to a relapse 3 to 6 months after treatment. And so we're really trying to also address that and learn more about it through different research projects, but also working to continue this care in that same intensive manner in the postpartum period, at least for the first year postpartum. So in summary, substance use disorder has affected our rural communities drastically. We have not a lot of prenatal providers that are comfortable in treating these problems. And our rural population is at the greatest risk of bad outcomes just because of the lack of access to treatment. Not a lot of great solutions for methamphetamine care during pregnancy, but quitting still helps, and we should continue to work and do more work in finding ways to treat methamphetamines. All patients need to be screened during the prenatal period and every trimester, but particularly when beginning the care. And there's a gap of training that we are trying to address through our curriculums, and just to emphasize that harm reduction practices such as MAT saves lives. Thank you very much. And these are my references.
Thank you. And we'll move on to California Bridge. So if you haven't heard of the California Bridge program, please check out their website. They've got a lot of great resources. And let me just pull this up here. Okay. And so we've got today, I'm pleased to have Chaya Vang and I think Stephanie Garcia Martinez are both with us today to talk more about California Bridge. Their substance use navigator program does amazing work, and Chaya Vang's have been really key to providing that support and linking our patients to care from the hospital to outpatient settings. So please welcome Chaya Vang and Stephanie.
Hello, everyone. My name is Chaya Vang. I am a substance use navigator for CRMC, like Dr. mentioned, and I'm very honored that she asked us to do this presentation. I am also one of the mentors for California Bridge. So I've been in this role for about 3 years. I started when California Bridge was first piloted, and CRMC happens to be one of the sites that was selected to do this. So we started the program. So I'm going to share my screen if I can. Okay. Can everybody see that? Okay. Okay. So we're Stephanie, are you on here? Probably not. Okay, so I have my contact information on there, and I also have Stephanie's contact information on there. So I'm going to talk about California Bridge at CRMC. So right when you walk into our ER, we have these posters in our ER, in our lobby. We have them also in our cubicles, in our fast track area, and spread out the ER. And some parts of the hospital, we have these posters up. And we just want to tell people that we are here to help. If you're struggling with any substances, you can ask for help. Our contact number is on there, and anybody can call us. And this is how we get most of our patients to self-identify. So with California Bridge, our goal is to start treatment during the hospital stay, whether when they come to the ER or if they're admitted, they can ask for help anytime while they're here. And we just want to make treatment as low barrier as possible. We do see all substances, we provide resources for all substances, but primarily where we have treatment for opiates. So primarily Suboxone, like what the two Dr. Klans were talking about. And anyone can ask for treatment anytime, 24/7. Unfortunately, we are not there 24/7, but we're able to do follow-ups and still connect people to treatment. And that comes down to our second goal, which is connection, to follow up, provide follow-up care for all patients in the community, not just follow-up care like to a clinic, but also resources that they may be needing, such as shelter, other documentations that they may be needing, not having insurance, stuff like that. And then there's also culture. So as substance use navigators, we are trying to create a culture change in our hospital. As we know, there's a lot of stigma, and there still is stigma even after 3 years at CRMC. There's still a lot of stigma from the staff, even from patients. So we are trying to advocate for patients and provide that environment, a safe environment for people to ask for help at any time. And we start off by using non-stigmatizing language, especially when our staff says, oh, there's an addict or somebody that's drug seeking, and we just simply correct them, oh, you need this person is in withdrawals. They may just need an extra treatment or an extra resource service. So just doing that. Also, a lot of culture change starts with sharing success stories. And I think that's one of the things that we as navigators are really good at, is that we go back and we share these stories that a lot of our staff don't get to hear or know. Tell them that this patient made it to care, or this patient didn't make it to care because of this. And just allowing them to see that other side, that once a patient leaves the hospital, that they don't get to see. And I think that's been very empowering to some of our staff that are slowly coming on and trying to minimize the stigma that we have for people with substance use. So this is our process in the ED. We get a lot of calls about what is the process, or how do I get help? And it's very simple, actually. If patients can self-identify if self-identify with their substance use, or they can self-identify when they come and register. It is easier. It actually helps speed up the process a little bit, if you want to say it that way. If they know coming in, they know what to ask for. So if a patient comes in and they ask for bridge services, or they ask to talk to me, or to ask for like Suboxone treatment, then like the nurses know, oh, they know exactly who to call. But when a patient comes in and they're asking what they can access, or abdominal pain, or the throwing up, then it takes a little more time. Obviously, they have to do workup, blood work, and urine, stuff like that. So that takes a little bit longer, and that's when patients may leave AMA. But when patients know to come in and they know exactly like the keywords to ask for, it just makes everything a little bit faster. And that also goes back to a lot of our patients knowing that we're there, having these posters available. Also, we have very good connections, like with working with Dr. Khan. He sends me patients all the time. And he asked me, oh, can this patient come in? Because I can't see them in clinic today. And we just say, yes, just come on by. So usually when a patient is identified, the nurse, doctor, social worker, whoever it is, staff can identify us. There are many ways to reach us. We try to be as convenient as possible to everyone. So we have cell phones. We each have our own cell phone. We have a desk phone. We have consults that they can order through our electronic system. They can message us. We have Voceras. So there's many ways to reach us if we're not reachable by any other ways. We will normally go see a patient. Go see a patient, do a very brief assessment. It depends on how patients are. If the patient is like actively withdrawing, like they're sick, we just do very brief. Oh, what are you using? How long has it been since you last used? And are there any like history of maternal Suboxone in your system? Have you ever had any of that? That starts off, and then we try to make, and then the doctors will normally treat the patients. Like I said, there's still a lot of teaching that needs to be done. So a lot of our physicians are not, they're not addiction specialists, obviously. So they go through like HALS score, and then that will kind of help them determine if the patient meets criteria to start treatment or not. If the patient doesn't meet criteria to start, then we kind of advocate for to see a doctor is X waivers, which is another subject. But the doctor has the ability to write a prescription for the patient to go home with to start at home whenever they are ready, and that kind of helps. So during our assessment, ER visits are roughly 2 to 3 hours, depending on wait time, obviously too. But if they're just there for withdrawals, and it's just Suboxone, and that's it. That's like their only complaint. Then it's about 2 to 3 hours. So we get them in and out with the prescription. Make sure that they get connected to a pharmacy that has the medication for them. Their insurance covers the medication. And we share all this information with the care team. So the nurse and the doctor knows what's going on while we're seeing the patients in and out. Usually after the patients normally feel better, then we go into more brief, more detailed interview with them. And then they will share. Normally when I just sit down and talk to patients, they spill the whole story to me. Like I don't have to ask them what happened when you were like 5 years old, or like why did you stop using and start it again. Like normally when I take the time, a lot of times when we just sit down and talk to them, these patients just tell us everything because they just want somebody to listen to them, and they just want to like share their story because they just want help. They just want somebody to listen, and they just want somebody to help them. So as navigators, we have that time to do that because that's all we're there to do. We're not there to do anything else but that. So that really helps us create this relationship with our patients, and that's how we build trust. So somewhere between there, we bridge the patient to treatment, meaning we offer them resources and we connect them to a clinic, at least one clinic or some kind of resource, so they can continue their the treatment, even if it's not actually medication-assisted treatment. Maybe it's just like a harm reduction resource. As long as we provide them at least one resource, that's bridging them. And then we do a warm handoff meeting. We will make the appointment for them, tell them what to expect when they get there. We are also on MION. That's what I forgot. Sorry. So MION is a on-call list that CRMC in Clovis has. Clovis Hospital. We share this on-call list, and we are on there. I am not a doctor. I don't know why it says that, but on there it has my number, my hours, and it also has Dr. Vora, who is our clinical champion. And Dr. Vora has been like the reason why our program is so successful in a way, because he helps us whenever we don't have an X-ray provider. He will jump in and help us get a prescription, and that's the best thing about having a clinical champion, because we have that relationship where I can just text him. I text him every day, and he will answer, and he will get me. He will help my patients get that bridging prescription if they need it, and he will also consult with the physicians who may be uncomfortable or don't know how to do treatment yet. So we also get a lot of questions on when do you reach out to a navigator when the patient's in the hospital. So anytime is actually a good time. When a patient expresses interest in treatment, that is the best time for us to intervene. If we miss the patient and patient gets discharged and we call them like a few days later, sometimes they may lose that motivation and they may not want to get treatment anymore. So we try to catch them when they are interested. When a patient needs buprenorphine follow-up, when patient wants information on buprenorphine, when there's an overdose. We do get questions about methadone. Do we need to consult, provide services to patients? Methadone is tricky. If patient is normally on methadone, that means they're already connected to services, but we do still go talk to them if they want additional services or they want to learn about Suboxone, and then we just provide them information. What about positive urine drug screens? We don't do testing in the ER for urine drug screen. California Bridge doesn't want, because doing testing means we don't trust patients, and we want to be able to trust patients. That's why we educate them as much as possible before we start them on treatment. So that way we can decrease the risk of precipitated withdrawals or decrease trust for whatever reason. So, but we do get, after patients do get admitted, obviously they do some kind of urine drug screening, and then we do get calls on those patients too. But those are the patients that are most of the time not ready for treatment yet. And psych holds, we unfortunately CRNC, we have a lot of psych hold patients because we are not licensed social workers or psychiatrists. We only go see patients when the hold is lifted or when they're safe for us to go see them. So normally we'll connect with the doctor or the nurse to make sure that it's okay for us to go see the patient before we actually, it's safe for us to go see the patient. I think that's what. And definitely pregnant patients, since this is a prenatal webinar, patients who are pregnant or just gave birth are at a stage when they're really motivated for treatment, and getting us involved to start this conversation increases the chances of them going into treatment and staying sober and getting to keep their baby. So definitely this is a great time to get the navigators involved. So when we bridge patients, when we start the referrals, there's a lot of things to consider. We share all the options of treatment to patients, which will be in the next couple of slides. There's different options. There's outpatient, inpatient, there's detox, there's primary care, probably more than that in the list. Things to consider. Sorry. Does the patient even have an ID? If the patient doesn't have an ID, they can't go into these treatment centers. So we have to help the patient identify that. If they don't have one, we can possibly get them a voucher or connect them to somewhere where they could get a voucher. Do they have their social security number? Transportation, which is a big one, something that Dr. Tan definitely expressed that it becomes a barrier. And then what kind of insurance do they have? A lot of patients that we see at CRMC are Medi-Cal patients. So with Medi-Cal, we do have limited resources, but identifying that kind of helps us along the way. And even like county insurance becomes a barrier, because I can't send a Madera County patient to Fresno resources just because of the whole insurance thing. And the patient geographic does the patient have a home, or are they unhoused? Are they safe, or are they at risk of getting their treatment medications stolen, or even their belongings? And then the patient availability versus clinic availability. Some of our clinics now, due to shortage of staff and shortage of staff and COVID, are about 1 to 2 weeks out. Inpatient programs are minimum 10 days out. So, but I hate telling patients that you have to wait to get into treatment. And I hate, it just makes it lose their motivation, but also it helps us also determine how long the patient may need prescription for, if they can get into the clinic right away, if they can get into treatment, maybe we connect them to a shelter or somewhere they can stay to be safe and not use until the clinic is available for them. So these are just some outpatient clinics that we have. This is my resources that we share to our patients. When we tell them about resources, we explain, we go through all these clinics with them, tell them give them all the options that are available. So that way we're not deciding for them, we're letting them pick which ones work for them. When I first started, I am very unexperienced. I don't know anything about these programs. So what I did was I did cold calls. I want to go visit these clinics in person, just so I know where they're at, what their intake processes are. So I myself can become almost an expert about these programs. So I could tell my patients what to expect too when I provide this warm handoff. So they're not surprised when we do this. And then these are our patient programs. All of these resources are Medi-Cal based, because like I said, most of my patients are Medi-Cal, and this is just a regular Medi-Cal Fresno County programs. Because I am part of California Bridge, I do want to share that we do have substance use navigators at most of our hospitals here in Central Valley. The ones I highlighted in yellow all have a navigator. The only one that doesn't have a navigator yet is St. Agnes, but we are all treating patients and we all provide this service all throughout California. As you can see on my map, there's going to be, our goal is to have all of the California hospitals to have a substance use navigator and to have a MAP program. I believe by 2025. So duties outside of the ER. I'm sorry, give me 1 second. So sorry. Okay, so we do follow-ups on patients. That's how we know how our patient outcomes are going. We do 7 days and 30 days. And usually I try to call them the day before the appointment just to remind them and also to do a little follow-up that they have an appointment coming up. We offer Narcan to all of our patients that may be at risk for overdose, meaning anyone who uses opiates, fentanyl, meth, even. We offer it to everybody. You don't have to be a patient to get these Narcans. You could just come in and ask for it. You don't have to register or anything. The only thing that we kind of record is gender, age that we sometimes guesstimate, and how many we actually give out. We do collect data for our grant because this is a grant funded program. We do obtain data. And then we do a lot of community outreach, and that's how we're connected to these clinics, shelters, harm reduction needle exchanges. All these clinic resources allow for us to provide the information about program, and for us to also like be able to treat patients, because these are where people go, and these people are gonna, somebody needs help. So just putting the word out there allows for us to be able to treat people more universal, be as universal as possible. We are also part of the Central Valley Opioid Coalition. There's also a Fresno harm reduction collaboration that we have started, and we're still working on this slowly. But yeah, so these are a lot of the things that we do. And I believe that is it for me. Again, this is my contact information. This is Stephanie's contact information. Our hours are Monday to Friday from 8 to 4 at the hospital. Thank you.
Thank you. And thanks for sharing. Let me bring up my. All right, and we are, so we're right at time now. I know we're going over the, I think you have to stop, sharing, there we go. We are recording this session, so if people need to leave, we'll be recording it and you can listen to it later. Hold on just a second. For some reason, I can't share my screen. Did we lose everyone? Okay. Oh, there we go. Sorry, technical difficulties here. Okay, now I think you can see my screen here. Okay, so I'm Dr. Robin Lynchide. I work at Fresno County Public Health as well as Clovis Community Hospital doing OB, and I'm a family medicine physician. I have no conflicts to disclose. So I wanted to just first begin by pointing out a few statistics on substance use disorder in Fresno County and our perinatal population. Getting accurate statistics locally on the prevalence of substance use disorder in our pregnant patients was quite challenging. There's not one standard way of collecting these results, and there's not a report. It's not a reportable disease, so it's not something we regularly collect data or that providers have to report to the public health on. Kind of standardizing this and getting better data collection is something that definitely needs to be improved upon. And I hope to address in our task force that we're creating, and I'll talk a little bit more about that in a little bit. But Chris Schreiber at Department of Behavioral Health sifted through some data and was gracious enough to put that together for me for on our treatment centers here in Fresno County, and how many patients we're treating who are pregnant at those treatment centers. So this gives us some idea of pregnant patients that come into care, but it's only at our medication assisted treatment centers. So it only captures a small portion of our patients and does not capture those coming into care through the hospitals or through outpatient clinic. And then one of the major ways in which we pull data on our population who has substance use disorder is through our hospitals. So I spoke with or community medical providers actually about a year ago, started collecting cord blood segments that they could run toxicology screens on if certain criteria was met. And so Sarah Putman, who's director of Women and Newborn Services there at Community, pulled some statistics for me on kind of positive results on those cord blood segments. And there's criteria that are met. Primarily, it's in babies who have neonatal abstinence syndrome or have symptoms, or mothers who have symptoms and trigger running those tests, as well as physicians or providers can ask for that test to be run. And as you can see the data here, primarily we see a lot of marijuana use, a lot of stimulant use, and that gets back to that meth use and how prevalent that is here in Fresno County. There is some opioid use here in red, and then a little bit of anxiolytics and anticonvulsants at the end there in orange and yellow. So the and on this slide we can look at how our numbers kind of compared nationally. So the gray here is our national average. You can see in Fresno County, our marijuana use is way above that, as well as our amphetamine and methamphetamine use. The opioid use is about at average here. And so these, again, we miss a lot of our patients because these only look at positive toxicology results on cord segments. And so there's a lot of patients who come into care who may be negative on a toxicology, but have a history or in treatment for substance use. There's a lot of patients who we just don't capture in this. And so we are not kind of pulling adequate or accurate numbers. The other thing is toxicology reports in cord segments, even urine drug toxicology results are very problematic in our pregnant patients because we use fentanyl and opioids in management of labor. We use benzodiazepines in anesthesia. And so there's a lot of positives that are from our own treatments we're getting them and doesn't necessarily indicate a substance use disorder. So why are statistics so important? One of the issues is that state, national, county funding is based on these statistics. So if they look at our numbers and say, hey, you don't really see any patients with this problem, we're not going to get that funding, and we're not going to be able to fund more programs to support our patients. And even more importantly, it helps us identify gaps in care and where we need more support and where we're seeing gaps or problems in care or difficulties in accessing care. So how can we improve this? One primary way is really to improve documentation, especially at that discharge from the hospital. So, really it's important as providers that we look at that history in their pregnancy. And this goes back to screening too, right? Screening for substance use disorder. And I know there's a lot of tools in even admission criteria that nurses can help with assessing for substance substance use disorder, but also looking at that history and whether they're in current treatment or they're seeking treatment, and including that diagnosis in that discharge so that we can more accurately identify and pull these numbers and get resources and support for our patients. So one of the ways in which I'd like to also work on this is through creation of this perinatal task force, substance use task force, and I'll talk a little bit more about that. We're also, our goal is to better coordinate care between agencies for our pregnant patients with substance use disorder. And we're also collaborating with the California Healthcare Collaborative to create this task force, and they have a lot of resources already in place across California that we can pull from and modify to improve that care, improve that screening and coordination of care for our patients here in Fresno County. So the goal of the task force, I really have to give credit to Dr. Tipu Khan for helping me with the idea of developing a perinatal substance use disorder task force. He's chair of the Ventura County Perinatal Substance Use Task Force there, and I had the opportunity to sit in on their meeting and see how well those task force works to address these gaps in care and coordinate care between agencies for our pregnant patients with substance use disorder. As I was working on this issue in Fresno County, I started to realize how disjointed our care was for our pregnant patients, and how little each agency knew about the other agency, and what they were doing to treat our pregnant patients with substance use. I originally started out with surveying our clinics and our CPSP workers on sort of their knowledge of substance use disorder in pregnancy and what treatments they were offering, where they would refer patients or whether they would keep them in-house and treat them. And through this process found that there was a huge lack of knowledge of the resources we had here in Fresno County and where to send patients and how to assess patients and get them into treatment. And that's where this task force comes into play. So our goal would be to identify high-risk perinatal patients in Fresno County who are struggling with substance use disorder and provide them with early intervention that is coordinated, trauma-informed, culturally sensitive, and comprehensive. Our ideal would be to see that all families afflicted by substance use disorder were given the opportunity to live healthy lives and provide them support so they can lead a life free of exposure to alcohol, tobacco, and street drugs. Some of the other ways in which we, the task force, I'd like to see them be able to eventually utilize community health workers to assist patients in getting care. I know transportation is especially difficult for a lot of our patients, so getting access to coordinated care and getting a number of services all in one spot is really helpful. So trying to coordinate that care better and decrease that burden of finding transportation to each visit is helpful. Also linking our inpatient to outpatient care services so there's no gap in that. So there's that warm handoff that California Bridge is so great at working at. And to really to educate our clinicians, educate our staff, educate our patients and our families is really important. And that's something we want to work at in this task force. So part of education is educating our patients, and our goal is to get more patients into care sooner and more engaged in care so they can have a healthy pregnancy and a healthy future for themselves and their baby. By screening and reducing stigma attached to substance use disorder, we can better engage patients and support them. So pregnancy is a time for you to feel engaged and supported by healthcare professionals. And by working with your pregnancy provider, you can have a healthier future for you and your baby. And I just want to show you this. So we developed this patient brochure And it is available in paper through Fresno County Department of Public Health, as well as we'll send it to you in the information that you will get after this webinar. And this is the brochure here. So it's a little bit about substance use, what treatment options there are for different types of substance use, and kind of do's and don'ts, what patients can do and what they should not do regarding their substance use during pregnancy. And then the back has some resources for substance use, both through Department of Behavioral Health here in Fresno County. There's a provider directory here in Fresno to find a provider for them. And then the Central Valley Opioid Safety Coalition has some resources here. There's a national provider list of providers who treat substance use disorder. And then SAMHSA has a lot of great patient and clinician handouts and resources there. And then on this page here, we just listed like the bridge contacts, behavioral health contacts, our substance use programs at WestCare and mental health systems. WestCare is the one you heard that video that Dr. Shoaib Khan shared with us and what they're doing. And then the rural health clinics with Dr. Khan and Parlier and Mendota, our narcotic treatment programs at Aegis, Medmark, and BART. And I just met with Aegis, and they've got some great programs there for moms and babies and for our pregnant patients. So that's our brochure. So again, let me know my contacts at the end. If you'd like paper copies, we can get those to you guys. And then it's available right now in English. We are working on translating it into Spanish and Hmong, and those will be available eventually too. One of the other ways in which you can refer patients for services is through this. The county has a high-risk OB referral system, and substance use disorder is definitely one of those high-risk OB categories that providers can refer patients, or CPSP workers can refer patients to services through the county by using this form, and I included the link there to refer your patients. So what can we do? If you work inpatient, please contact that California Bridge Navigator to help patients get into care and treatment and link to services. Consult that addiction specialist. I know Dr. Shoaib Khan, Dr. Vora are both down at Community Regional Medical Center. I am a clinical champion through the SUSTAIN grant for Clovis community, so please feel free to contact me. I am also X-waivered and able to provide scripts for Suboxone, so if you need that linkage from inpatient to outpatient, please don't hesitate to contact me or one of our other addiction specialists. And then if you work outpatient, you can refer to Fresno County Department of Public Health through that high-risk referral form, referral to behavioral health for their substance use services. You can also contact that Bridge Navigator on an outpatient setting to help you out. Refer them to the Harm Reduction Clinic with Dr. Shoaib Khan. You can refer them to treatment centers for medication for addiction treatment. And like I said, Aegis, I just met with them, and they've got some great programs for our pregnant patients and are working on some support groups and stuff for them. You can also get X-waivered, and it's really important that we try to get as many providers X-waivered as possible so they can write that prescription for Suboxone and get patients into treatment for our opioid use disorder so that they can maintain those levels and not have those highs and lows and have a healthier pregnancy, healthier baby. And then also giving your patient access to naloxone. Naloxone is free and available through Bridge program, through the ER at CRMC. You can get them in your office. You can write a script for patients to get it at the pharmacy. So really important for them to have access to that life-saving treatment for anyone on narcotic pain meds or narcotic meds. So there's additional resources here. There's a hotline for moms and kids that they can call through the public health. Behavioral health has some resources, and let me just show you their website here. So that's the link to their website here and their resources. California Bridge, as Chaya talked about, their website is just a wealth of information. If you're going to start buprenorphine, they've got a pregnancy one. They have a huge, they have a nice flow sheet. They've got flow sheets on treatment outside of pregnancy too. So really helpful, especially as you're getting started with maybe starting out with just Suboxone or medication treatment for opioid use disorder. And then the California Maternal Quality Care Collaborative, they have this toolkit, which Dr. Tipu Khan helped write, and it's a wealth of information for providers, really great resources. There's the toolkit goes through just different topics on like treatment, assessment, and pretty easy to navigate. So they've got screening and assessment, treatment, transition of care, and education. And so lots of good information there. And I think that is, let me go back in here. That is all I have. So thank you so much for attending today. We are so pleased to have a great turnout. Really, I'm really happy there's so much interest in this topic, and I think it's so pertinent right now, especially. Now I want to open it up for questions. I think Stacy has been monitoring the chat, and we'll start with questions there. But before we do that, we will be sending out all the slides that were on here, as well as the video recording and the handouts. So you'll be receiving all of that, as well as a evaluation form. So please fill that out. And thanks for sticking with us. We went a little over, so I will open it up for questions now.
We did have a question in the chat for Dr. Tipu Khan. Do you have a preference between Suboxone or buprenorphine for pregnant patients with OUD?
Yeah, that's a good question. We used to years ago teach that buprenorphine mono product was what we wanted to use in pregnancy, aka straight bupe, and not use Suboxone. But a lot of good expert consensus out there over the years that either one works. In general, I try to avoid the mono product buprenorphine because there is diversion potential with it. But every once in a while, you will have a patient that will tell you that the mono product makes them nauseous or has a reaction. So in the end, whatever the patient will take, I will give them. But I have a preference for the combo product to prevent diversion.
Okay, thank you. If you have a question and would like to ask it audibly, please feel free to raise your hand using the little raise hand feature, and we'll call on you to ask. Another question in chat was, what is meant by prenatal screening? Is it questioning? Does it include a urine tox as well?
Did you want me to take that one?
And if you would like to, it was asked during your presentation.
Okay, so yeah, the prenatal screening is a broad term that includes a lot of different things. In the terminology that we were using for prenatal screening in that presentation was some type of a validated screening tool. So it's a questionnaire. So you ask the patients, like with the 4 Ps, there's a questionnaire you go through and ask them, have they had drug exposure in the last X amount of time, etc. And once you come up with that, it gives you a score and tells you, if they score in or score out for concern for a substance use disorder. So it is a questionnaire. There is also, of course, urine toxicology testing, which does play a role in screening as well. However, it's a whole topic in and of itself. We have to be careful that we don't prejudice ourselves and that we do a urine drug screen on this patient because they come from, this clinic, and not on this other patient because they come from another clinic, or they look this way. So I would recommend, if you do institute drug screening as part of your standard practice, it should be universal. Everybody on initial intake, etc., gets a drug screen if you decide to go down that pathway. or if it's indicated. For example, if they're there for preterm labor, or they're there for abruption, an obstetric indication of a medical complication, a urine drug screen is part of the standard workup.
Yeah, I'd also like to add too with that, with urine drug screen, it's really a tool to help with treatment, and shouldn't be, it shouldn't be punitive, or shouldn't be, to catch a patient. It's really, it's helpful in if they are in treatment to see, are they taking the medication appropriately? Why aren't they taking it if they aren't? Are they using other substances that we didn't expect? And why are they doing that? Did something come up positive and it's a false positive? Because there's a lot of false positives. So yeah, I agree with Dr. Khan. It's a whole nother lecture, but it's definitely a useful tool, but has to be used in context of everything. I also saw, Stacy, someone mentioned with the X waiver, that it is true that, so the X waiver, you no longer as a physician have to do any training for that, to be able to treat up to 30 patients. You just have to, but you do have to apply for that X waiver, and that is to treat substance use disorder or opioid use disorder. If you are using Suboxone or buprenorphine for pain control, strictly pain control, then you can prescribe it without an X waiver. But if it is used for that opioid use disorder, you do need the X waiver. You just don't have to do the 4-hour or 8-hour training. If you do the training, you can treat up to 100 patients with the buprenorphine.
And we are working on offering a webinar where physicians can log in, get some additional information, and get help filling out the X waiver paperwork. Doesn't take very long at all. We'll help you walk through that and get you waivered. There was a question in chat also inquiring as to whether Bridge was Fresno only. California Bridge is statewide. We did put that link to the californiabridge.org website in the chat for anyone who would like to go. They have amazing resources, unbelievable wealth of information. Highly recommend you checking out the website and getting connected with them.
Yeah, and I can tell you, I just went to a national conference for substance use, and they referred to California Bridge multiple times. So people across the nation are looking at the website, using those resources because they are that good. The advantage of being in California is we have those access to those substance use navigators, which are throughout California.
There was a question about if we could include the dopamine video when we send out the information this afternoon. And so if I can get a link to that, I'd be happy to include that in the email that goes out this afternoon. But that's it for questions that were in chat. So if there's anybody that would like to open their mic and ask a question, you can feel free to do that now. The contact information for all the speakers is included at the end of their slide decks. So you will be receiving that when you get the email this afternoon. So if you have additional questions or something that you didn't want to ask live, you can reach out to any of our amazing speakers and get some answers.
Yeah, and thank you to everyone who helped put this together. Thanks for everyone who came. We had a great turnout, and I'm so glad that we're just getting the word out. And please, just share the video. Stacy and I were talking about. It will probably be uploaded to YouTube, and so you'll have access to the video too, so that you can share it with your colleagues, and please contact us if you have any questions. and fill out the survey, please.